it's a difficult system overall. And as much as we try to improve the system and make the system flow better and whatever, I mean, we're limited, partially by resources alone. When I think of, the number of, say, for example, service coordinators that we have, which are the people who are they're the hub, right? You got a question, you call the service coordinator because they're the one that knows your family and I know what you need and all that. When I look at my service coordinators, they have, I would say on average, 90 to 100 families each that they're responsible for. So, I'm surprised sometimes they remember people's names because it's hard to keep track of 100 families because they're not typically just involved with one child either. They're coordinating for the family, which means they could have 2 or 3 children that they are dealing with within that family. So it's not an easy job. And when you look at the resources that we have in the community, we don't have the amount that we really should have when we think about it. There's a lot of kids out there with a lot of difficulties, and when basically you're at a level of response kind of to crisis, meaning that, if you come in with a minor problem, we really can't deal with that because we don't have the people. Because if you're in crisis, we're seeing you immediately, right? And I think that often the system is pushed to that level of we're in crisis all the time. It's hard to get to those cases that are simple. And what happens when you don't get to the cases that are simple? They get worse and they eventually become crises and we see them anyway. But, really we should be looking at how can we pour resources into the front end, not into the back end, right? But in order to do that, we'd have to have a lot more resources than are currently available. What I will just say in general to the answer to that question is that Children's Services only goes up to their 18th birthday. So technically, he's not eligible for Children's Services at this point. Adult Services start at 16, okay? This is a little glitch that we have in our system in the sense that Adult Services start at 16, Children's Services go until 18. So you would think that the 16 to 18-year-old population is twice as likely to receive services when in fact they're falling through the cracks more often than anybody else. And we're not entirely sure why that is. We're trying to fix it, but at first we got to figure out what the cause is and why that happens. So, but I do have resources for you, so come see me. Anorexia and bulimia was the question. Which, I mean, mental health issues, if I had to get here tonight and go through all of them, we'd be here till next week. There are tons of them. There's a book this thick that lists them all, which is nice. It's something that is a concern. I mean, we do see a fair amount of it, but by comparison, when we look at the number of kids who are coming through, they make up a small proportion of the population that are seen. Like I would say by far anxiety and depression and behavioral issues related to anxiety and depression make up the lion's share of the referrals that come through the doors when we're talking about kids. When we're talking about teens, it's more likely to be gravitated towards the depression side of things. You might be likely to see a little bit of first episode psychosis, and that's where you're likely to see also the anorexia and bulimia being a little bit more of an issue is in that group. But realistically, again, when we talk about psychosis or anorexia and bulimia, those numbers are a lot lower compared to these other issues. So part of the thing was, as a committee, when there was some discussion about this, it was, what do people really want to know the most about when it's the things that are the most prevalent in the community? Not saying that we won't address that at some point in the future. You know, if they continue that after this year, we'll see what the word is on that. I guess it depends on how successful it is. So if you really like it and really want to know, good reviews, and maybe they'll do it again next year with different topics. And they can invite me back. I think in terms of stuff like that is a great idea, and we're very much about, you know, if we can destigmatize mental health. And one of the biggest problems we have, of course, is the fact that a lot of teenagers who have significant mental health problems don't want anything to do with the mental health system because of the fact that they say, I don't want to be seen as a mental health patient, which who can blame them given the way that it's often portrayed, right? Whereas, like I said, mental health issues, people have them. You pass them on the street every day and it's not the crazy person on the corner that you think it is. It's somebody that works with you. You know, it's somebody that you would never know. So when you think about it that way, well, why wouldn't people, you know, want to be upfront about that? People don't have any problem going around talking about their medical issues, right? You hear about that all the time at work. Somebody comes in and goes, oh, my back is killing me again, and and I've got this going on, and my sciatic is acting up again, and it's the weather, and I've got these migraine headaches, and but you don't hear somebody come in and go, my clinical depression is killing me today. I'm really feeling suicidal, and don't come in my room and ask me to do that again. Because if you come in my office, I swear. You don't hear that kind of stuff. People don't want to talk about it. It's not fun to talk about, and there's such a stigma associated with it. People go, I don't want anybody to know. They sneak into mental health clinics because they don't want anybody to see them wearing sunglasses. Things wrapped around their head. It's not something that people want to share. So that's why I say I'm not going to ask in the room, because I know that most people, even if you go, yeah, I know, but I'm not going to put my hand up, right? That's a tough question. So if you catch something early and try to address it, is it going to make a difference later on? And I think that is highly dependent upon what the issue is. So for example, if you're talking about something like, let's say, anxiety and depression, they are extremely hereditary. So you can have a very large genetic predisposition towards that because of the fact that you inherit it. So the good thing is that if you provide treatment early enough, we can provide skills, we can provide coping mechanisms, we can provide things that will help people so that it doesn't have such an impact on their life. It's not going to make it go away. It's not going to magically make it disappear. But as an adult, you would be functional because of the fact that you've addressed these things and you know how to deal with it. When you get to other types of problems, there is a chance that we can, yes, sort of nip it in the bud and it's done. And we're not going to worry about it later on. You might have a relapse, but realistically, we can take care of it. When you get to things that are more complicated, like psychosis, a little bit of a different story, because I think preventing that is not as easy as it would seem. So that's likely to manifest if it's going to manifest. We don't want to do anything to encourage it manifesting, but I don't know what you can do to make it not manifest if that's going to happen. So it really depends on what it is that you're trying to address. But what we do know is that kids who have issues, who receive treatment, often have much better outcomes than kids who are not identified as having issues and don't receive treatment.
I was just wondering, because you refer to treatment a lot, it doesn't necessarily mean medication.
No.
Right.
Treatment is going to depend on what the problem is. And I'm not one to push medication in the sense of saying everybody has to have medication or else it's not going to work, right? But for example, we know for kids who have significant depression symptoms, when you have depression and it's that significant, often what happens is you don't have a lot of motivation. You don't have a lot of motivation, you don't have a lot of motivation to change, is what that means. So doing cognitive behavioral therapy or talk therapy with somebody who doesn't have any motivation to change, typically not very effective, right? So what we know for those individuals is that a little bit of medication to take the edge off, allow the motivation to kick back in, the cognitive behavioral stuff works much better, and then you wean them off the medication. So it's almost like it needs to be a hand-in-hand thing. But depending on the type of problem, you can't take somebody who's got a psychosis and who has psychotic breaks and do talk therapy with them to prevent the psychosis. That's something that you need to have medication for. There's no getting around that. And there's other things that you probably don't need medication for and you can deal with without any difficulties. Everybody reacts to medication differently. That's part of the problem, right? We often make assumptions about the fact that medication will be the silver bullet to, be the cure-all for everything, right? And it's not necessarily. And in a lot of cases, these medications have been tested on adults, but not tested on children. There's a whole ethical thing about testing untested medications on children. Who knew, right? So we don't know what the impact is of a medication on a child, for example. So what happens is we say, okay, you know what, this is what it does to adults. Children are like miniature adults. So the child brain is a miniature version of the adult brain, therefore this at a lower dose should be about the same sort of thing. Like sometimes that's the mentality, right? Whereas we know that a child's brain is not the same as an adult's brain because a child's brain is still developing. And most adult brains are, I don't want to say they're not developing. They're not developing as rapidly as a child brain. So what does that tell us? Well, that tells us that a medication that impacts a certain way in an adult is not necessarily going to have the same impact in a child. And I would say the same thing for most people. Everybody's brain is different. Every person is different and unique. And some people's reactions to certain medications are going to be different than other people's. So we always have to make sure that, again, when we go down the route of medication, we talk about what does medication do. Sometimes we have to try 2 and 3 different things before we find the right one. Because just because most of the world does very well with Prozac, we know that there is a subgroup of people that Prozac makes suicidal. So, you know, it's a great drug. It does a whole lot of good for a whole lot of people, but there's a certain group of people that it's not very good for. That's why we always monitor when we give medications to say, this is, you know, this is what's going on, this is what you can expect. Keep letting me know, because if there's any issues, side effects or whatever, we need to change things. So having a good physician, or good, I would say in this case, a good child psychiatrist is what you really want, who's going to know the medications and be watching for those little things, because they're going to want to tweak this and that to make sure that it works the best way possible. Because we don't want to just say, okay, here's this prescription, run with it. That's not good treatment. I would say that if the child is under the age of 6, you'd probably be calling children first. And barring something unusual, you could be looking at us if you're over 6 and under 18. And then we will tell you what you should do in terms of where to go or whatever. If it's not appropriate for something that we offer, or it's something that we don't offer, but these people offer it, we will make the referral and get you there. That's, you know, the idea that around the brokerage model that we do, and the one that we support, is the idea is that if we can't give it to you, we'll try to find somebody that can. And whether that requires us to, you know, call London or call wherever and find out where it is that you can get what you need, we're at least going to get you going in the right direction. No idea. What I know is that there's been a large push towards decreasing the number of beds. Yeah. So we're arguing actually to increase our numbers because we're over capacity. But the bottom line is that, yeah, they're trying to regionalize, so remove those, you know, we're going to have all the beds in London and that's where everybody's going to go. They're divesting, beds are going back to their home communities, smaller numbers, you know, that kind of thing. But in terms of, I know what we have in beds for, in essence, what is the Erie, St. Clair, Lynn. So that would be Windsor, Chatham, you know, all of Essex County, Kent County, doesn't include Sarnia. We have 6 beds. Yep. Outside of that, I'm not sure what the numbers are. Everybody has anxiety at some point. You know, I can think of multiple times in my life, whether it be the geography test that I didn't study for, or getting up in front of a bunch of people and talking. You know, things like that cause people anxiety. Anxiety is a normal response. It is a response that is hardwired in your brain, and it's there to protect you. Because the idea is that, you know what? If I'm out going around in my jungle environment and there's rustling in the bushes behind me, I think I need to pay attention to that and figure out what is that, because it might eat me. I mean, that's there for self-protection. That's why we have anxiety. The difference, like I said, when it comes down to it at the end of the day, is that whole continuum of psychopathology. That is, everybody has anxiety, but where does anxiety become a problem? Anxiety becomes a problem when it interferes with your day-to-day function. So if I can't leave my house anymore because I'm too scared to go outside, because a plane's going to fall out of the sky on my head, or something like that's going to happen, or I don't want to see people because, God forbid, if I see people, they might look at me the wrong way, and then I don't know what I'm going to do. I might throw up, and if I throw up, oh my God, I'm going to be so embarrassed. You know, people think like that sometimes. If it's interfering with your day-to-day life, then you've got a clinical disorder. Then you need treatment, because you need to have better quality of life than being, you know, holed up in your room. because you're afraid to come out. So anxiety is normal. Too much anxiety, not so normal. I would be very anxious if somebody came up here right now with a weapon and threatened me. That's situational. And I think nobody would argue that that was a wrong response, right? That's the thing. So situational anxiety is okay. I mean, if that happened to me and then I can't leave my house anymore because I'm afraid somebody's going to come up to me, then that's trauma related. That's more along the lines of like PTSD. That's an anxiety disorder. That's a different thing because there's no reason for me to anticipate that would happen. So why am I worried about it? That becomes a problem. But yeah, I mean, it's a normal response. Typically what happens is that, if you tell somebody within the school, there's a whole set of, I guess you could call them safeguards that are put in place in the school. So the idea is that, for example, that principal would know that if this person says something like that, then I need to call such and such person. The Greater Essex Board, for example, has what I'd like to call a little crisis team who will actually go out to the schools and then meet with the students and talk to them and do whatever. And if they feel that there's an issue, then they're going to direct that person, for example, to the ER. They contact our crisis workers, say, here's what happened. They came into the office. They talked about this, this, and this. They fill them in. Our workers go over and do the evaluation, and then we determine whether or not they need to be admitted to a bed or not. So there's a whole kind of process that comes into play as soon as a child reports something. But if they don't tell anybody, nobody knows. They are all in Windsor-Essex. And we service the southwest, well, I guess it's not the southwest region, but the Erie, St. Clair, Lynn region. So if there is a child in Chatham or somewhere in Kent County that requires the bed, they are transferred here to Windsor. And they're serviced here. That's why via OTN we're actually doing the evaluations of the kids in Chatham, because technically they're within our catchment area. So we're trying to, of course, like I said, argue for the need for more beds because, we need them. What can I say? I don't like having kids up on peds. It's not fair to the kids. It's not fair to the families. They're not getting what they need because they don't belong on a medical unit. That's not helping them. And in some of those cases, those kids are on forms. Now, forming is a process that if you've got an individual who has a significant mental health problem, you think they're at risk to themselves, you can actually, a doctor can write on this thing called the form, and the form basically says that you are not allowed to leave the hospital for a period of 72 hours, which is the psychiatric evaluation time, right? We've actually had kids who have been formed who are sitting up on peds and their forms are running out and they're having to go back and reform them because we can't get them into a bed and they're formed. This is not even we think you should go into this hospital bed. This is you're not safe to leave the hospital situation. So, yeah.
If they are put on peds.
Yep.
Are psychiatric nurses assessing them or pediatric nurses?
Pediatric nurses. Well, I mean, when they're on peds, the pediatric nurses are caring for them. We will often send staff members to go monitor them while they're on peds because the pediatric nurses are dealing with the medical issues. And it's hard for them if we say this child is formed, they're suicidal, you can't have a pediatric nurse sitting outside of their door all night long. And it's great to say the parents can come in and the parents can monitor their child, but realistically, if they're on a form, it's not the parent's responsibility either. So the bottom line is we staff. We have people go in and literally sit outside their room and check on them every 15 minutes, make sure they're still asleep and everything's okay for the entire night, for as long as they're on peds. Issue in the sense that, because of Windsor's declining population, or Windsor-Essex, I should say, that they're looking at the likelihood of us receiving more money is getting smaller and smaller because other areas where the population growth is increasing and increasing, they need more services. Therefore, there's only so much money to go around. And when you have the bulk of the budget, the provincial budget being in health, it becomes a bit of a crisis in and of itself. So I know we're saying we're only arguing for, can you give us like 3 more beds? We're not asking for a lot, but realistically, we're not the only people asking for 3 more beds. So it becomes an issue of where does the LIN decide to spend its money at the end of the day? We're making a very good case for it. We're arguing, every day to make sure that they get the message that this is something that really, really needs to be addressed.